There are some questions which I think either of you can answer. One of the question is from Dr. Rajiv Gupta, who says, what is your experience on sudden cardiac death as a presentation for COVID patients coming to the hospital?
So, I think that we don't know what the true incidence of the sudden cardiac death is. I can tell you that it's even harder because respiratory arrest can manifest as sudden cardiac death. One of the things we did see with the New York State EMS is that our arrests everywhere, and this is in Europe, here, all went up. We don't know which of those are more respiratory versus VT-VF. So I suspect that it's a combination of the two. I also suspect that there are younger people who delay coming to the hospital for a variety of reasons, and then they have an arrest, and we don't know whether that's primary cardiac or respiratory induced. So I think there's still a lot of work to be sorted out, but I think we'll start seeing data on this relatively soon.
And the subsequent question was, how do you protect your healthcare workers in United States apart from the PPEs? Is there still a suggestion that people take chloroquine, hydroxychloroquine on a weekly dose?
No, so at least from my perspective, there are randomized studies going on. And we'll see. I think the enthusiasm to be in those randomized studies has gone down with some of the data on hydroxychloroquine and also the issues with regards to monitoring. I will say one thing about PPE, because this is important. The Chinese and the Italians told us, and I was an advocate in the hospital telling the administrators left and right that we needed to wear full hazmat suits and we needed really, really to be protected in that way. Obviously, more protection is better than less protection, but I can tell you we did not have that degree of protection. But once we instituted N95 masks and then also universal masking of all patients in the hospital, the rate of infectivity of the staff in terms of the hospital was really low. And I can tell you, I told our infectious disease people just last week that I was wrong for insisting or trying to insist that you needed full on everything. I think that this is a respiratory spread illness for the most part. And all of the fears that we had about contact spread and all of that were largely mitigated by washing hands and sanitizer and that sort of thing. So that's just one thing I think that's an important learning, because there's a lot of fear about this. And I had it myself, but I can tell you I was probably wrong.
Yeah, and because hydroxychloroquine in India is still advocated by the ICMR, which is the Indian Council of Medical Research, and not many, but I have seen some patients coming to, not even patients, some healthcare workers, asymptomatic, non-COVID people coming with, VT, torsades, and one or two of them actually dying or requiring a shock. So I really don't think that there is a strong indication to take hydroxychloroquine as of now, unless you are actually dealing with a COVID positive patient. So otherwise, the problem is that in India, most of the healthcare workers, and even at home, even if they are not sitting at home and not working, they are on hydroxychloroquine therapy, which is...
I gotta say that there's now multiple randomized trials really not supportive of that, and I don't know how this happened in the beginning. It was sort of really insisted by the French initially, and nothing against the French, but everybody wanted to sort of do what they could. But now we have several streams of data showing that it's not only not helpful, and we know it has a narrow therapeutic window too. So, I know it's hard to say, but honestly, if our president hadn't come out with the statements he made, I wonder if even India would be in a different state. And knowing how much he knows, frankly, it's really remarkable to me that this all happened.
True.
Yeah, I can also say that our protocol at Mount Sinai was to use hydroxychloroquine universally during the peak of the pandemic, and obviously that has completely changed now. But there were, thousands of patients that were on this drug due to the popularity based on really, minimal data at the time, which was unfortunate.
And there's another question from Dr. Madhukar Katiyar. He says, what are the lab parameters in asymptomatic infected persons and in so-called super spreaders? And at which stage of infection do you find these lab parameters to be positive?
Yeah, I think that's a great question. I think it's tricky though, because oftentimes the asymptomatic patients are not presenting. So it's hard to really say what lab abnormalities you may find in someone who's otherwise routinely asymptomatic, otherwise, unless they're coming for another reason. But certainly for those patients who were presenting with even mild symptoms, for example, I'm a heart failure cardiologist, so I took care of heart transplant patients who were coming in as well. Even if they had mild symptoms, sometimes these laboratory derangements helped better triage these patients and helped us monitor them more closely. I think a patient who came in with a markedly elevated D-dimer and gross derangements and inflammatory markers would make me think twice about letting them, for example, stay at home as opposed to watching them in the hospital.
And another question from Dr. Katia, role of corticosteroids in COVID patients who are admitted in the hospital.
Yeah, I think that's a really interesting thing. I think, the recovery trial is informing its potential benefit. We haven't seen the exact publication yet, but certainly we were using it almost uniformly, but, we're eagerly awaiting seeing that primary data. But honestly, anyone with severe respiratory symptoms, then we had a protocol for this in terms of oxygen saturations being less than 94%. A number of inflammatory markers, we would put patients on steroids. I don't know, Dr. Kirtane, if you had a different experience.
For us, the steroids it was a no-no. It was really interesting. We made protocols. We were using hydroxychloroquine and we weren't using steroids. And then we basically stopped using hydroxychloroquine right around the time we started using steroids. And then that was supported now, obviously, with the recovery trial. But I think that it's important to understand it's not for everybody. And certainly in the trial, it looked like the sickest of the patients were the ones in whom the dexamethasone, had the mortality benefit. And so I would try to stick to the science and I would try to stick to the data rather than sticking to emotions and trying to help people, because sometimes we hurt them when we do that.
Thank you all very much. And we had many more questions, but because of paucity of time and we have to stick to time, we are already 5 minutes delayed. I thank you all for joining in. I know it's a working hour for both of you in New York and also Dr. Call. And I'm really grateful and I honor your time and also your support for the Asia Pacific Vascular Society in our meeting for last many years. Thank you, especially Ajay, and please convey my regards to Dr. Greg Stone, who also gave a wonderful talk on the first day. Thank you all very much and stay safe.
Thank you.
So can we have the next panel, please?